Thank you very much for the kind introduction. It's a great pleasure to be here today, at least virtually, and I would like to thank Professor Kotsis for the kind invitation. I will present over the next minutes how to manage anticoagulation in patients with intracerebral hemorrhage. This is actually a challenging topic, and in regards of epidemiology, fortunately, this is not a very often situation. However, almost 25% of intracerebral hemorrhagic events occur in patients under treatment with oral anticoagulation, with annual incidence of 0.5 to 1%. It means that annually 75,000 of ICH survivors have an indication of oral anticoagulation in Europe and in the US. The most frequent indication is atrial fibrillation in almost 20% of intracerebral hemorrhage survivors, and importantly, the prevalence of atrial fibrillation and ICH and their comorbidity is expected to increase with the aging population over the next decades. Thus, there is a clinical dilemma, an existing clinical dilemma, whether to start or not to start antithrombotics in intracerebral hemorrhage survivors with atrial fibrillation, and physicians have to balance the risks, the risk of thromboembolism against the risk of rebleeding. The decision is challenging given the lack of high-quality evidence, as these patients have been excluded from all pivotal randomized controlled trials comparing DOAC with vitamin K antagonists. On the one hand, if we do start, there is the risk of ICH recurrence. On the other hand, if we do not start, there is the risk of a cardioembolic stroke, the most devastating type of ischemic stroke. And although the CHA2DS2-VASc score can help us with risk stratification for thromboembolism, the Hasbled score has limited predictive value in the setting of intracerebral hemorrhage. In order to assess the ICH recurrence risk, several factors should be taken into account, including neuroimaging parameters, bleeding topography, hematoma size, and of course severity of bleeding and type of bleeding, small vessel disease burden using MRI imaging, and also genetic factors such as ApoE, epsilon-2 and 4 allele status, and most importantly, modifiable risk factors such as blood pressure control, concomitant medication, and alcohol abuse. And focusing further on factors affecting the brain, previous studies have shown differences of ICH recurrence risk depending on the location of the index bleeding. And this is because intracerebral hemorrhage topography may offer insights into the etiology of the cerebral bleeding. Deep intracerebral hemorrhage has been consistently associated with hypertensive microvascular disease, whereas lobar ICH is mainly considered as a manifestation of underlying cerebral amyloid angiopathy. And we do know from observational studies that patients with lobar ICH have 2 to 3-fold higher annual risk of intracerebral hemorrhage recurrence. Those lobar ICH location indicative for probable CAA, cerebral amyloid angiopathy, represents a major risk factor for recurrent ICH. Besides bleeding topography, it is very important to also evaluate small vessel disease markers, such as cortical superficial siderosis, convexity subarachnoid hemorrhages, cerebral microbleeds. All of these are visible only in MRI scan in specific sequences, for example, gradient recalled echo or susceptibility weighted imaging. In everyday practice, we call this T2 star. And of course, ischemic lesions should be taken into account, namely white matter hyperintensities and perivascular spaces. Importantly, the revised Boston criteria, the Boston criteria are some criteria that we use in everyday clinical practice to say that the patient has probable or possible cerebral amyloid angiopathy, because the gold standard, a brain biopsy, is not feasible and is not the right approach in everyday clinical practice. So the revised Boston criteria provide high diagnostic accuracy for the identification of patients at especially high bleeding risk, such as cerebral amyloid angiopathy patients. Those going back to risk stratification, the thromboembolic risk should be balanced against the individualized bleeding risk, taking into account all these factors, and ideally, this should be done by a multidisciplinary team, incorporating patients and family preferences in the lack of strong evidence. And let's move to the available data. What is the current evidence? We have some positive results from observational data over the last years, suggesting that oral anticoagulation resumption in patients with atrial fibrillation after intracranial hemorrhage may be beneficial. However, this study should be interpreted with caution because of selection bias and confounding by indication. This is the nature of because of the nature of the observational trials. We have some small randomized trials showing some encouraging results, although they show also benefit of resumption. However, the net clinical benefit is still unclear. The main phase randomized control trials are still ongoing. And finally, we have the opportunity to obtain results from individual patient data meta-analysis under a collaboration across all research groups in the field. The name is Cockroach. That may inform ongoing randomized control trials, but also there is an agreement that all data from all randomized control trials will be meta-analyzed in individual patient data meta-analysis. And here are the results from the first prospective individual patient data meta-analysis on behalf of the Cockroach collaboration from the first completed randomized control trials published last year in Lancet Neurology. This individual patient data meta-analysis included 412 participants with intracranial hemorrhage and atrial fibrillation. Patients have been recruited in Europe, Canada, and Japan. The trials, all trials were open label. The elder care was placebo-controlled trial. All trials compared oral anticoagulation. In 99%, the OAC was DOAC. Actually, DOAC were compared with no anticoagulation. Then the control arm, the no anticoagulation arm, included patients who received antiplatelets or no antithrombotics. And here are the baseline characteristics. In terms of the baseline characteristics, there were the two groups were well balanced. 75% of the included patients were aged of 75 years or older. 70% had a CHA2DS2-VASc score of 4 or more. It means that there were patients at especially high thromboembolic risk. 40% were females. 1/3 of the participants had a lobar topography, and the median timing of resumption was 75 days post the index bleeding. Here you can see the pooled analysis. And as you can see, OAC resumption reduced by 73% the ischemic major cardiovascular events, a significant reduction without to significantly increase the hemorrhagic major cardiovascular events, which was defined as intracranial hemorrhage and major extracranial bleeding. However, it remains uncertainty about the net clinical benefit with OAC resumption, although these results are encouraging, and of course, they encourage the further recruitment into the larger ongoing randomized control trials. And here you can see the status of the ongoing randomized control trials. This table has been updated mid-May after personal communication with the PIs of the trials. Prestige AF, one of the largest trials, has been also completed recruitment and follow-up, and we are waiting the first results over the next months. And of course, after the completion of all trials, we will have the opportunity to have a meta-analysis, an individual patient meta-analysis, to have definite answers about the net clinical benefit with oral anticoagulation resumption. What about, however, as mentioned before, patients have different bleeding risks, especially patients with cerebral amyloid angiopathy are at a higher bleeding risk. What about these patients should also may also these patients benefit from OAC resumption. Unfortunately, for these patients, we have not specific analysis, but we have this communication. We have some encouraging data from one observational study with all limitations of observational studies. However, these findings have been not confirmed by randomized controlled trials. This is a correspondence published last year in Lancet on behalf of the Enrich AF Steering Committee, the largest of the ongoing randomized controlled trials, stating that the trial stopped enrollment of patients with lobar intracerebral hemorrhage and cortical subarachnoid hemorrhage. More specifically, after a safety review of the first 700 patients, 1/4 of them had lobar ICH, and based on observations of unacceptable high risk of recurrent hemorrhagic stroke in patients assigned to the edoxaban arm, this study compares edoxaban versus no oral anticoagulation. The DSMB recommended that participants with lobar ICH had to stop the study drug as soon as possible, and also the trial stopped the recruitment of patients with these specific ICH subtypes, cortical subarachnoid hemorrhage and lobar hemorrhages into the trial. However, these results are still unpublished and are not available. Nevertheless, the individual patient data meta-analysis of the 4 small RCTs that I showed you earlier didn't show any interaction between the bleeding topography and the net effect of OAC, however, in 100 participants. So this is still an ongoing problem, and we need a specific subgroup analysis in showing the benefit or the risks of OAC resumption in terms of topography and underlying etiology. What about other solutions in ICH patients at especially high risk? For example, the patients with cerebral amyloid angiopathy. Left atrial appendage occlusion offers an alternative for these patients, for patients at very high bleeding risk. And data from left atrial appendage occlusion look promising. However, trials on left atrial appendage occlusion are very small compared to the large oral anticoagulation trials that included thousands of patients. We should also have in mind that most left atrial appendage occlusion trials used VKA as as a comparator, which is inferior to DOAC in terms of bleeding risk. Data on the left atrial appendage occlusion in ICH specifically are very limited. And also the safety of left atrial appendage occlusion followed by doublet and platelet therapy that is required after the occlusion, the first months after the occlusion, is not known for ICH risk, especially for these patients with high bleeding risk, such as cerebral amyloid angiopathy patients. However, even in this topic, left atrial appendage occlusion is currently tested in randomized controlled trials with DOAC, and we will have good evidence in the future. But until the completion of all randomized controlled trials, what can we do in the everyday clinical practice? This figure by Andreas Karidimou depicts very nicely how we can approach patients with cerebral amyloid angiopathy. At this point, let me make clear that for patients with deep hematomas, especially for small deep hematomas, although we don't have finalized large clinical trials, the impression is that we can restart safely anticoagulation with DOAC. The problem is patients at especially high bleeding risk. For these patients, we need to evaluate the small vessel disease burden. We need MRI scan for decision-making in these patients. And so patients with low small vessel disease burden, with low number of cerebral microbleeds, without cortical superficial siderosis, disseminated cortical superficial siderosis, without recurrent lobar ICH, we know that these patients may benefit from resumption of oral anticoagulation with direct oral anticoagulation, which are safer for the brain because they reduce the risk of recurrence by 50%. For patients at especially high bleeding risk, patients with a large small vessel disease burden, maybe we should consider left atrial appendage occlusion. For patients who are in the middle, in the gray zone, maybe both strategies could be beneficial, but we need more data from the randomized controlled trials. For sure, we have to reassess the risk over time, to reevaluate our patients because cerebral amyloid angiopathy may change over time, and more lesions can be developed over the years. And of course, we need general measures to mitigate the risk. For example, good blood pressure control, to avoid medication that may increase the bleeding risk, and also to encourage patients to stop alcohol. And of course, we need to reevaluate regularly our patients. And let's move to the last question, the most challenging question, which is the optimal timing of resumption. There are just a few observational studies addressing this question, the question of optimal timing. These nationwide registered retrospective observational studies focusing specifically on timing of WAC resumption in patients with intracranial hemorrhage and atrial fibrillation suggested that it would be of benefit to restart between 7 to 8 weeks. However, the results should be again interpreted with caution because of the observational nature of the study. And the uncertainty about the optimal timing is reflected in the international guidelines. American guidelines suggest to restart between 7 and 8 weeks, as mentioned before, based on this observational study. However, European guidelines suggest to start earlier at a time point of between 2 and 4 weeks. Of course, the optimal timing should be considered should be decided on a case-by-case basis, and should be based on individual risk assessments of thromboembolism and recurrent ISH. Of course, patients who are at especially high thromboembolic risk should restart earlier, and a very good paradigm for that are patients with mechanical heart valves. Here we have a good study, observational study, but very good design from Germany. This is a study from the Retrace cohort, and investigators suggest in patients with mechanical heart valves to restart anticoagulation between first and second week, between day 6 and day 13. And of course, the decision depends on the type of the mechanical heart valve, and patients at especially high risk are considered the patients with mechanical mitral heart valve and concomitant atrial fibrillation. Patients with mechanical aortic valve without atrial fibrillation can restart around day 14 after the index bleeding. And of course, this is a difficult decision, and always we have to collaborate. We need a multidisciplinary team to discuss in order to individualize the risk for each individual patient. Dear colleagues, let me conclude that restarting anticoagulation after intracerebral hemorrhage is really a difficult decision. This is a challenging question. This is a clinical dilemma. And what we do know so far from clinical trials and clinical research is that oral anticoagulation reduces the risk of ischemic major cardiovascular events. However, there are still uncertainties for the hazards and net effects of oral anticoagulation in intracerebral hemorrhage survivors, because intracerebral hemorrhage is a heterogeneous disease, and we need subgroup analysis to see which patient will benefit from resumption, and who is at especially high risk for bleeding. For these patients, left atrial appendage occlusion may offer an alternative, but we need more data from RCTs that are still ongoing. Definitely, patients with mechanical heart valves should restart anticoagulation. Unfortunately, here the only solution are only VKA antagonists because DOAC have not an indication for mechanical heart valves. But here we know that we can wait for at least 1 week, and of course, we will start earlier than in patients with atrial fibrillation, but we can wait for 1 week, especially in high-risk ICH, for example, larger bleedings and severe bleedings. And of course, the completion of all ongoing randomized control trials will resolve all our uncertainties in the near future. Thank you very much for your attention.